Okay, so here we are for ECG 2. I want to tell you just a little bit about these ectopic focus. So the first thing I want to say about the ectopic focus is that all cardiac muscle cells can become an ectopic focus. The primary reason they don't is that the sinoatrial node typically keeps them all in line, and it does so by depolarizing first. If you do not remember resting membrane potentials and action potentials from anatomy and physiology, then I suggest you go back and take a look at what resting membrane potentials are and what action potentials are. It's important to know that. I'm going to be talking about things that I assume you know from previous coursework. So the SA node depolarizes first because it has the shortest refractory period. Basically, if this is our SA node, the membrane potential of the SA node, it gradually creeps up to a threshold where it depolarizes and then repolarizes, and then it gradually gets to where it hits the threshold again. This is happening in the SA node. This is the electrical depolarization and repolarization, and then the resting membrane potential of the SA node. It is happening quite frequently. You would get depolarization of the SA node in resting conditions anywhere between 50 to maybe 80 times per minute. This equals your resting heart rate. So your resting heart rate basically reflects the depolarization pattern of the SA node. This slope reflects the time, influences the time it takes for the SA node to depolarize again. All the other cardiac cells take longer to depolarize. And therefore, by the time they get to their natural depolarization time, they're already depolarizing because of the action potential from the SA node. So they don't ever get a chance to initiate their own action potential. They initiate an action potential in response to the SA node's action potential because it has the shortest refractory period. And this is the refractory period. It's the period that it is in its resting state. In the heart, the resting state of these cells is not the same as in the nerves or in the muscles. In the nerve and the muscle cells, the resting membrane potential is constant, or should be constant. It does not slope upward toward the threshold of depolarizing. This fact that cardiac muscle cells slowly depolarize, they don't have a steady state resting membrane potential, is why we say the cardiac muscle cells have the trait of automaticity. Automaticity just means they will automatically depolarize in a cyclic or repetitive nature. Anything, any perturbation in a cardiac cell that would cause it to not have a delayed or long refractory period and slow rise to its threshold for depolarizing could cause that cell or cluster of cells to become an ectopic focus. Common things that will cause cells, cardiac cells, to have an early depolarization, earlier than what the SA node wants, are caffeine. Stress hormones, catecholamines can do it. Sort of pathological things would include cardiac ischemia. So any reduction in blood flow to the myocardium, where the myocardium is forced to use anaerobic glycolysis to generate ATP for its contractions, can reduce the pH, impair ion function, ion channel function in the cell membrane, leading to more rapid repolarization and ectopic foci. So the way it looks, well, let's see. The way it looks, if it's in the ventricle, is you've got this big, awful looking waveform. It is not preceded by a P wave. Just all of a sudden, you get this big waveform that is depolarization of the ventricles independent of the SA node. Now, why is it so big? Well, the main reason for it being large and particularly wide, wider than the QRS complex, is that action potential is traveling through the ventricle by a means other than the normal conduction pathway. So let's say these cells right here depolarize. They spread through the ventricle using another route, just through muscle fibers, than through these yellow conduction fibers. And it takes longer for them to travel, and it travels in awkward directions, and it leads to that large, abnormal looking pre-ventricular contraction. When you start having a lot of them coming from different ectopic foci, that's more severe. Here's one PVC. Here is multiple PVCs non-stop. So this is ventricular tachycardia. If you go back to the table in the handout, one non-stop ectopic focus in the ventricle is ventricular tachycardia. And this is what that looks like. Here is ventricular fibrillation. We have multiple ectopic foci in the ventricle all over the place, leading to no concerted contraction of the ventricle, so there's no sign of all the muscles contracting at once in the ventricle. They're just all the fibers contracting at once. They're just happening all over the place, and we get this scattered line. Clearly, this is not conducive to blood flow. You do not get a contraction of the myocardium that will increase pressure and eject blood. Here, while you're getting a contraction of the myocardium altogether, you're doing it so fast, there's not enough time to fill. And it leads to difficulty ejecting blood, which leads to no ejection of blood, which leads to myocardial ischemia in more cells, which is why ventricular tachycardia tends to progress to ventricular fibrillation. Atrial fibrillation, as you can see, is much more benign. It's not benign, but is more benign than VFib. You can live with AFib. You cannot live with VFib. So atrial fibrillation, we see we've got no discernible P wave. There's no clear-cut time when the entire atria is contracting at the same time. And we get an occasional QRS complex. And they're not regularly spaced. Every so often we get an action potential through the AV node that makes the ventricles depolarize and gives us a normal QRS complex. This is atrial flutter. We've got regular ectopic foci nonstop in the atria. We got 1, 2, 3, and then a QRS. 1, 2, 3, and then a QRS. 1, 2, 3, and then a QRS. So we get 3 contractions of the atria for every time we get a QRS complex, for every time we get a depolarization of the ventricles. This is not healthy for the atria. They eventually get too tired and end up going into atrial fibrillation. Here's another example of atrial flutter. Okay, so the other big set of problems that can happen, so this is the first big set. The other big set of problems is when the ECG changes because of a problem. So let me. So the other thing I said in video 1 was when a problem leads to a change in the ECG. Okay, so let's take the one problem we're going to look at is ischemia. And what happens with ischemia is that we get a lack of blood flow that leads to a lack of oxygen, which leads to predominant glycolysis and lactate accumulation. We eventually don't have the energy to return to membrane potential. If it becomes reversible changes, it can become an injury. Irreversible changes become infarction. Ischemia and or injury can lead to an ectopic focus, or worse, ectopic foci. Now, ischemia can be located or can be observed before it becomes an ectopic focus. So before the ischemia or injury leads to the problem of an ectopic focus, it leads to a change in the electrocardiogram. So the problem is the ischemia. The change it can lead to prior to becoming another problem is ST segment depression. So ischemia leads to ST segment depression. What ST segment depression is a lowering of the point of the ST segment, which is the point from the S wave to the T wave. So going back to this diagram, here we see ST depression. We've got P, Q, R, S, and then we've got the T wave. This is the ST segment, and here we're seeing it 2 millimeters lower than the normal isoelectric line. And that is ST depression. It is a sign of ischemia. The lower it is, the less likely it's a false positive. The lower the ST segment, the less likely it is a false positive. Another sign, we have reduced ST segment. Here we see that there are different types of ST depression. One of them can be called one's upsloping, one of them is horizontal, one of them is downsloping. So horizontal, greater than a millimeter, has the lowest error rate, and the error rate here would be the rate of false positives. So we've got the highest error rate is associated with upsloping waves. It just could be a normal finding. So it could be normal. As a sign of ischemia, it could be wrong 30 to 40% of the time. ST segment elevation occurs once the myocardium has gone from just being ischemic to being injured. And here we see ST elevation. When here's really obvious ST elevation. It's so elevated the T wave is lost within the elevation. And then infarction, here we see it doesn't even look like a normal QRS. We've just got such incredibly large Q waves. So what infarction can lead to is something called Q waves. I think the most important thing for you to take from this is that ischemia leads to depression of the ST wave, and that if that continues for too long, it can become ST elevation. Typically, once we get ST elevation, the person usually rules in and ends up having a myocardial infarction confirmed later. ST segment changes occur locally in the area of ischemia or injury, meaning you might not see ST segment changes on every lead of the electrocardiogram. Okay, so it's been 15 minutes. I'm going to stop here and then do a third and final video on electrocardiogram.